Hello everyone. The topic of discussion today is regional injuries. In this we will learn intracranial hemorrhages. Now, whenever there is a trauma to head, the blood vessels get ruptured and this leads to bleeding inside the head. So now, based upon the type of blood vessels that are getting injured and the age of the patient, there are different type of regional injuries or intracranial hemorrhages. We are dividing in called epidural hematoma, subdural hematoma, intracerebral hemorrhage or subarachnoid hemorrhage. Now how are these different? We need to first learn the basic structure of the brain. See, we need to learn this brain meninges. So now between the skull vault and the brain matter we have three meninges, three layers which goes by the name durameter, arachnoid meter and pyometer. In between these two layers there is space and we are naming this space. The space above dura is extradural, below dura is subdural and below arachnoid is subarachnoid space. Okay, so this is extradural, subdural and subarachnoid space. In between this space there are blood vessels. So we have middle meningeal artery in extradural space, bridging veins in subdural space and circle of Willis in subarachnoid space. Now, whenever there is trauma, these arteries get ruptured, and due to the rupture of these arteries, there is hemorrhage or hematoma. So now, here in extradural space, there is an artery, and in subdural space, there is a vein. So, which one do you think is more dangerous if it's get ruptured? If artery get ruptured, then there will be more bleeding, or in venous rupture. See, think logically. The heart pumps blood inside the arteries. So, arteries are having high pressure blood. So, if artery gets injured, then there is high pressure outflow of blood in this space, and whenever there is more blood it will compress this brain more. So the arterial rupture is more dangerous. So in a sense I can say that the epidural hematoma is more dangerous than subdural hematoma. Why? Because it has artery. Now whenever an artery ruptures there is high pressure bleeding. So you can see that it has occupied a larger lens shaped area and it is compressing the brain more. While in subdural hematoma you can see that there is a vein rupture. So that's why there is the bleeding is more spread off like this and it is not compressing that much in compared to epidural hematoma. Second thing here is that epidural hematoma does not cross sutures, while in subdural hematoma it crosses the suture lines. So in epidural hematoma we have middle meningeal artery rupture, which will cause a lens shaped hemorrhage. Why? Because it is high pressure arterial hemorrhage and it is compressing a major part of the brain. So we have biconvex lens shape or lentiform hemorrhage which does not cross suture, while in here the hemorrhage is more spread out because venous rupture there is slowly emission of blood will come out slowly. So there is banana shaped concentric hemorrhage and it crosses the suture lines. Now see, whenever there is hemorrhage inside the brain we are having symptoms like paralysis and why, and that why? Because this compresses the brain is composed of nerves. So whenever the nerve is compressed in here, the body part it which the body part that the particular nerve controls, that will be affected, so we'll get symptoms. The last one is subarachnoid hemorrhage. See how it is different than these two is that the hemorrhage is inside the brain tissues, while in subdural and epidural, the hemorrhage was outside, just in the meningeal layers. When it is inside, it will cause a focal neurological deficit. What does that mean? That means that whichever part get compressed, whichever part get compressed, that symptoms will occur. Like if this area is compressed inside the brain, then whichever body part this area is controlling, that will be get damaged. So we'll have focal neurological deficit in subarachnoid hemorrhage. Why? Because it is coming inside the brain tissues. So different parts are controlling different functions of the body. And highest fatality is in obviously in intracranial hemorrhage because arterial bleeding and high pressure bleeding. So this was overview about all these three type of hemorrhages. So now we'll study in depth about particular hemorrhage. The first one is extradural hematoma. So how this occur? Whenever there is a blow to this pterion region, blow to this is temporoparietal region, and this is a pterion point, which is the point where there is least safety, which can rupture easily. So whenever there is blow to the pterion, there is fracture in the temporal bone. So this temporal bone gets fractured and the middle meningeal artery, which I showed you, gets teared. Whenever the artery will get teared, there will be bleeding, and that bleeding is called hematoma, right? So we'll have extradural hematoma, and this bleeding raises intracranial pressure. Obviously, if there is more blood coming out in the brain tissues, then it will raise intracranial pressure. So again, the extradural hematoma, which is the artery, middle meningeal artery. So now, okay, let's see. So let's say the artery got ruptured here and there is a bleeding. So now this bleeding is compressing the brain. So whenever this brain is compressed like this, then there will be this brain stem will herniate out due to that pressure. So we'll have brain stem herniation, and we'll know brain stem controls respiration and all etc. Right? So we'll have brain stem compression due to raised intracranial pressure. Now this will called brain compression. This is called brain stem. This brain stem will herniate, that will cause respiratory failure and death. In this is a feature of what? Extradural hematoma. So now frequency, it is the least common. Why it is least common? Because to cause extradural hematoma you need a high force blow, which usually occurs at the age of what? Young adults. Why? Because young adults are involved in bike, involved in driving etc. Children and old age people don't drive, right? So it requires that much amount of blow to create this hemorrhage, and it has highest fatality among intracranial hemorrhages, which I'll keep saying. Why? Because its artery is rupturing over there. The type of injury is unilateral cope injury. See, there are two type of injuries. Whenever they get impact, whenever we get impact, if the injury happens in the point of impact, that is called cope injury. And if it happens in the opposite point due to this brain hitting over here, that is counter cope injury. So extradural hematoma is an example of what? Cope injury. Now we learned that whenever there is blow to the temporal temporoparietal region over here or pterion, the artery which get ruptures is middle meningeal artery, and this one is the most common. But the other arteries also get ruptured based on the location where the impact is happening. So we have anterior ethmoidal artery, and the region is frontal lobe. We have transverse sinus in the occipital lobe and sagittal sinus in the vertex. So when different regions get involved, different arteries are ruptured. The most common over here is middle meningeal artery. So now there is, what are the clinical features? Obviously, the first, let's imagine a patient is having a blow. Due to that blow, there will be, see, due to that blow, there will, let's say at this point the person got hit by a road or an accident. For some time he will be unconscious. Why? Because that trauma creates concussion. What is concussion? That electrical activity inside the brain is disrupted for some time, so the patient is unconscious for that same time. Now imagine, here there was trauma, so at the same point there will be artery rupture. So artery is also ruptured over here, but this unconsciousness is not due to arterial rupture, that is due to electrical activity disruption for this particular period of time. So there is, the patient will be unconscious. So the patient has trauma, then concussion means the electrical activities are disturbed, so he is unconscious for a particular time, so for some moment of time. Now the electrical activities are coming back to normal, so he is conscious again, but the artery also got ruptured here, so the bleeding is continuous inside the brain. There is, the patient is conscious, but slowly the artery is bleeding. Now why the arterial bleeding is not causing unconsciousness over here? Because the artery, when it bleeds, it needs certain amount of blood to cause that brain compression. So the patient will be conscious here, but their arterial bleeding, the brain is slowly getting compressed, and when the amount of blood increases, the patient will again be unconscious. So we have two unconsciousness, and in between that two unconsciousness we have a conscious period which is called lucid interval. And we can see that in this time the patient is aware or awake, but there is brain compression due to bleeding. So this is called lucid interval, which is a consciousness between two unconscious periods. And now when the patient gets conscious, the bleeding continues, and after some time he will be dead. So let's imagine that the patient came inside the hospital. He was unconscious, and when he became conscious, the doctor discarded him and he went home. After some time, the bleeding continues and he will again be unconscious and death. So if a doctor fails to diagnose this lucid interval, then doctor can be punished, right? So failure to diagnose lucid interval is a medical negligence. And in this period when patient is conscious, he is acting normally. So he can be give a valid evidence or whatever crime that he saw. If he tells anything, he is talking properly, he is not under any intoxication or anything due to this bleeding, and will be criminally liable. If he commits any crime in this conscious period, he is criminally liable because he is not like any under alcohol intoxication, or he is in proper sense during this period, right? So now I told you that when patient was unconscious and he became conscious, the doctor discarded him. But how will we know that there is brainstem compression going on inside the brain? We cannot open the brain as such, right? But we know that whenever there is bleeding, the brain gets compressed, and depending upon the compression, it compresses what? The nerves, and the nerves controls our body parts. So the symptom will be dilated and fixed pupil, because it will be compressing something about the third cranial nerve. That bleeding is compressing the nucleus or anything of related to third cranial nerve in the brain. So we are having dilated and fixed pupil and contralateral hemiparesis. What does this mean? If the trauma is here in this side of the brain, then the opposite side is paralyzed, contralateral hemiparesis. Why? Because the bleeding compresses the brain nerves and the parts are paralyzed. So whenever the patient comes, if he is of trauma, if he is unconscious and he become conscious again, check for this sign. Is his pupil dilated and fixed? Is he having contralateral hemiparesis? Then he is in the lucid interval. Do not discard it, and we have to treat the patient, right? So 35 ml of blood will cause the clinical features, while 150 ml of blood is fatal and cause death or injuries. So now I told you why there is contralateral hemiparesis, because this part of brain, the fibers crosses, and the opposite area is controlled by this part of the brain. So there is contralateral hemiparesis. Now I told you that whenever the patient is conscious, there will be dilated and fixed pupil and contralateral, the opposite side hemiparesis. But in certain situations, there is Carnohan's notch phenomena. In this thing, there is dilated and fixed pupil, same, but there is ipsilateral hemiparalysis. Means if the trauma was here, then this part of body gets paralyzed. Why so? Because see, the paralysis is happening because there is bleeding, it is compressing brain, and the part of brain which is compressed, that is paralyzed, controlling which parts of the body. So in Carnohan's notch phenomenon, what happens is, let's say that bleeding is in this part of the brain, then the see, this is what tectorium cerebelli, and this is falx cerebelli. So whenever this bleeding is here, it is somehow compressing the opposite part of the brain. So the bleeding is here and it is compressing the opposite part of the brain. Then the symptoms will appear on the same side of the brain. Why? See, again, bleeding is here, opposite part is compressed. So whenever this part is compressed, then the paralysis will happen on the same side. So trauma was here and the paralysis also here, so it is the ipsilateral hemiparesis in certain cases. So this is a misleading sign that we have to identify. So what is the mechanism? There is uncal herniation and compression of the opposite area into the tectorium cerebelli. So the opposite area is compressed, and compression of fibers in the cerebellar peduncle, which will cause ipsilateral hemiparesis. And dilated pupil is same in both the phenomena, right? So now what are the investigation? Investigation first is NCCT of the brain. I explained you it has a lens shape appearance. Why? Because it's arterial bleeding and it does not cross suture. So in CT we see a lens shaped hemorrhage, biconvex or lentiform hemorrhage. What is the management? See, this is an acute condition. If the clot gets bigger in size and compresses the major part of the brain, it can lead to death. So we have to surgically remove the skull piece and remove the clot. So surgical removal of the clot. Second is craniotomy or burr hole craniotomy, in which we create a hole to rear. See, this is a more invasive surgery, this is less invasive surgery. So the management is surgical removal of the clot or craniotomy. See, now note, lucid interval is more prominent in extradural hematoma than in subdural hematoma. Now we are studying subdural hematoma. As I told you, in subdural hematoma, the blood vessel involved is what? Bridging veins, and it has what? Banana or concentric shape hemorrhage. Now, this extradural hematoma cannot be chronic. Why? Because whenever there is impact, there is high arterial bleeding. It will immediately compress the brain and symptoms will occur. So, there is no acute, subacute, chronic in epidural hematoma. While in subdural hematoma, we have acute, subacute, and chronic phases, which is divided by duration. See, if it's less than 3 day acute, 3 day to 3 week, it's subacute, and greater than 3 weeks is chronic. And lucid interval is also present in subdural hematoma, but it is less prominent. And see, now this one is the point of differentiation. It occurs in minor trauma in elderly. Why? The epidural hematoma we studied occurs in age group 20 to 40, wherever they are involved in high strenuous activity and they are causing high impact. Here it is caused by minor impact and in elderly. Why? See, this one is in children. In children, whenever the children is subjected to any torture, there is shaken baby syndrome, which is the parent or any guardian usually shakes the baby. So there is damage over here. So this is acceleration deceleration in injury, means the acceleration when it is moving here, there is acceleration and then suddenly coming in this side, so this deceleration. So acceleration deceleration injury causes subdural hematoma due to rupture of what? Bridging veins. Done. Now, two age group this happens. Subdural hematoma happens in elderly and in children. Now how does it happen in elderly? See, whenever there is minor trauma in elderly, the elderly brain, this one is normal physiologically, the brain is atrophied. So let's say these are the two layers of the brain. So whenever brain gets atrophied, the space increases. So there is enlarged subdural space, which will cause bridging veins to lose the support. So if this was the space, then the veins between them are properly held. If the space increases, the vein loses their support. Why the space increased? Because age related brain atrophy occurred. So in elderly, if they even fall down or it's not that much of impactful trauma, even then they have slow bleeding going on in the brain, which should be diagnosed, right? So subdural hematoma occurs in what? Elderly and in children. Slow bleeding going on, which can cause what? Chronic subdural hematoma. And the age group over here is children and elderly. Now, what are the clinical features? See, clinical features are same. We have dilated and fixed pupils, hemiparesis, which was same in the extradural hematoma. Others are headache, altered sensorium, and personality changes. In elderly, these are the symptoms that you should see. If the elderly is having this type of symptoms, then it might have encountered a minor trauma, which is slowly the vessel is bleeding inside his brain. Investigation over here is also same. NCCT, I told you, it has a concentric banana shaped hemorrhage. We discussed this earlier. It crosses the suture line. Management is conservative if it's not that much, or surgical removal of the clot that I showed you images. Now there is another concept. See, what is dementia? Dementia is like the memory loss. And why does it happen? Dementia occurs due to many reasons: Alzheimer's, vascular, a lot of reasons. Let's just talk about Alzheimer's. What happens in Alzheimer's? There is brain atrophy, which is causing dementia or memory loss. Simple. Why it is relevant here is there is a symptom called dementia pugilistica. also known as punch drunk syndrome. What happens here is the boxer is getting a lot of trauma, chronic trauma in his entire life. This will cause what? Repeated brain injury due to trauma. Whenever a thing or any part in the body injures, there is inflammation and healing. Whenever there is healing, there is contraction. Let's say a wound in your hand, like whenever it heals, there is a blackish thing and contraction. So it will cause healing and scarring, which will cause brain atrophy. And as I told you, the atrophy is causing what? Memory loss. So this is dementia pugilistica seen in long-term boxers. Dementia means memory loss. Why it is having atrophy? Atrophy is having because there is repeated trauma and scarring. So this is most common seen in what? Subdural hematoma, right? So the last one here is subarachnoid hemorrhage. See, why does subarachnoid hemorrhage happen? Now, as I told you, the first two that we discussed earlier were in the layers of the brain, while this is inside the brain matter. So it is subarachnoid hemorrhage. Why does it happen? See, these are the normal blood vessels. This is artery venous connection. Whenever they get tortuous, there is arterious venous malformation. Now this tortuous thing can get rupture and the blood can leak. So this will cause subarachnoid hemorrhage. So if due to any pathology there is AV malformation, whenever there is trauma, this can get injured and there will be bleeding. So this is AV malformation. Second is Barry's aneurysm. Here you can see this dilated part. Okay, this is called Barry's aneurysm. This also can rupture and cause what? Subarachnoid hemorrhage. Third one is trauma and stroke. So now what are the clinical features? See, important thing is, as I told you, the first two were outside in the meninges, while this one is occurring inside the brain matter, subarachnoid, and in here inside we have cerebrospinal fluid. So whenever this blood will irritate this cerebrospinal fluid, there will be thunder cap thunderclap hemorrhage, which is like the worst hemorrhage of anyone's life, and it is so painful. And the patient will describe you that I am having the worst headache of my entire life. So this is sudden onset. Why? Because it is due to trauma and severe headache. Why it is so severe? Because it is irritating this cerebrospinal fluid inside the brain matter. Second is nausea, vomiting, neck stiffness, drowsiness and loss of consciousness, and focal neurological deficit. As I explained, whichever part of the brain will be compressed, that symptoms will occur, right? Most important thing here was it will irritate this CSF. So now how will we diagnose this? We'll just go by the concept what I told you. The blood is going and irritating the CSF. So this you can see is the normal CSF, and this is CSF with blood. Now logically it should be red, right? CSF is white, blood is red, so it should be red. No, but it is yellow or xanthochromia. Why? Because the blood, when it gets decomposed or whenever there is digestion of that blood, it will create yellow pigments. So we will have xanthochromia, which appears at 4 to 6 hours. And how will we remove the CSF? Via this lumbar puncture process. We'll remove the CSF, analysis it. If it's xanthochromia, then the diagnosis is what? Subarachnoid hematoma. And we can also do NCCT of the brain, where we'll say hyperdense bleeding near base of the brain. What is the management here? See, management was the rupture was causing due to this aneurysm breaking. So we have clipping of aneurysm, first surgery. Second is endovascular coiling. See, here we have inserted this and it is coiled, so the blood doesn't go in aneurysm. If it goes in aneurysm, there will be bleeding, right? So the blood just passes off. So management, we have clipping of aneurysm and endovascular coiling of aneurysm. Now see, logically, if you think, how will we differentiate both subdural? See, this is subdural and this is subarachnoid. In postmortem differentiation, how will that occur? So if you can see that if this in postmortem differentiation, I remove this skull base, and if I pour water over here, this bleeding will get washed away. But this is inside the brain tissues, so this clot will not get washed away. So in subdural hemorrhage, the hemorrhage is washed away, while in subarachnoid, persist. Why? Simply because it is here. So if you logically just remember this image, you can learn a lot of facts like, see, this bleeding is inside and there is CSF. So the symptoms is thunderclap hemorrhage. Why it is not getting worse? Because it is inside the brain tissue. So everything, you don't have to learn everything, just have to apply the logic. So now quick differentiation or comparison. The vessel involved is middle meningeal artery, bridging veins, and circle of Willis, extradural, subdural, and subarachnoid. The CT shape is biconvex lens, crescentic banana shape, and hyperdense base. About the crossing the sutures, extradural doesn't, subdural does. Age and lucid interval prominence.